Hello, I'm Brad Elmer. I'm going to be doing a review on Hematology, and that right there is my cat Thor, so hopefully he stays nice. So the first thing to know about Hematology is it's pretty straightforward. There's only two real labs you need to know. So the first lab is PT, or prothrombin time. You need to know this lab in regards to warfarin and Coumadin only. Generally speaking, your PT or INR should be 1. Otherwise, if you are using heparin or Coumadin, you're going to want a value of 2 to 3. So that means your blood level, the higher the INR PT, is going to mean that that's the thinner your blood is. So therapeutic range is going to be 2 to 3. Unless you have an artificial heart valve, then you want their blood to be slightly thinner. So you want 2.5 to 3.5. Now, someone with an artificial heart valve, the reason you want their blood a little thinner is that artificial heart valve is going to collect platelets on the valve. And so once those platelets are collected in the valve, your heart will beat a little stronger, throw one off, and you have a stroke or DVT, PE, or something like that. So artificial valves, 2.5 to 3.5, otherwise 2 to 3. The other value you need to be aware of is an APTT, which is activated partial thromblastin time. Basically, this is going to be in regards to a heparin infusion only. Now, there's a PTT and APTT. The APTT is activated. It's basically they have chemicals in the vial that actually causes the blood to coagulate faster. So usually the APT is a quicker, smaller number, and the PTT is going to be a longer number. Basically what the number is that it is how many seconds it takes for that blood to coagulate. So in heparin, you are thinning the blood out. You want to make sure you're not causing them to bleed out too quickly, and so you're going to measure that time. So, of course, lower number, coagulating faster, longer number, the blood's thinning out. So anything over 80 seconds or an 80 is going to be too long and too thin. There's another test you can go over, and that is a D-dimer test. The D-dimer test is basically, D-dimer is used kind of as a general screening tool. It's a byproduct of clot breakdown. So if someone has a PE or something like that, they should have an elevated D-dimer. If they don't have elevated D-dimer, you can rule that out. But the only problem is you can't just go off of a D-dimer test to show they have some sort of clot, because the D-dimer can give a lot of false negatives. Alright, so the first medication I'm going to talk about is heparin itself. So heparin is going to comes in two forms, either IV and sub-Q heparin, or there's a low molecular weight heparin, which is called Lovenox. If you are giving heparin IV, it's going to be a weight dosed titration. Generally, pharmacy will get a baseline APTT, get their weight, start to drip, titrate from there. What heparin's doing, it is going to stop. So you always know there's like coagulation cascade, there's different clotting factors from your liver, so on and so forth. So it's going to basically stop with factor X, factor 10, I should say. So main thing to be aware of is heparin is not going to decrease the size of any clots. It's not going to lead to the breakdown of clots. It's just going to allow clots not to become larger and allow your body to naturally break down the clot itself. So with heparin, basically what you need to know is you are going to be aware of any signs of bleeding, gums, tarry stools. Be aware of any sort of GERD, jabs that can be ulcerations. You're also going to need to have a 2-nurse check-off, because certain hospitals, certain policies are going to want another nurse to verify that your heparin drip is accurate, because it can be very life-threatening. There was a nurse I worked with. She grabbed the wrong bag of fluid to give a patient a bolus, and she bolused the patient with heparin. So it's very important you are assessing what you're giving. So generally you will check an APTT every 4 to 6 hours, depending on your policy, and then pharmacy will titrate the dose from there. The other thing to be aware of is making sure they don't. You can have heparin-induced thrombocytopenia, so the heparin will actually affect the amount of platelets they have in their body. So you also have to assess not only the APTT, but also their platelets, and ensure that they have an accurate amount of platelets, and you're not just destroying what they have. So even though your APTT might be an appropriate number, their platelet counts are getting dangerously low. They're going to end up having complications of bleeding anyways. The other thing you need to be aware of is the reversal agent for heparin, which is protamine sulfate. So basically, if they are having huge signs of bleeding, when that you give protamine sulfate, will help reverse the action of heparin. It'll start that clotting cascade again. The other thing to be aware of is with Lovenox or enoxaparin, which is that low molecular weight heparin. It has a longer half-life, so it's kind of slower acting, so it's a little more controlled. So what you can probably see is they probably won't really test an APTT with someone who's on Lovenox. So if someone who's on Coumadin therapy pre-surgery, what they'll generally do is they will stop Coumadin a week out, switch them over to Lovenox, and then have the Lovenox stop a day before, and then they'll go into surgery. That's what I saw with my mom's knee surgery. She was on Coumadin for a while for PEs. And so you kind of like switch from one anticoagulant to the other. So the next one is actually going to be Coumadin or warfarin. This one is very important. It's very strong acting. This basically will stop a lot of clotting factors by primarily stopping vitamin K from having an effect. The thing to be aware with warfarin and Coumadin is a very long half-life. So the INR and PT you are assessing, you will check it for daily for the first several weeks they're on the medication to verify where the numbers are going to be at. Then you titrate their dose from there. The other thing to be aware of is you need to tell them to keep their vitamin K intake normal. So basically, it's going to be your green leafy vegetables, fruits, not really fruits, but vegetables, keeping that vitamin K level consistent. So if they eat spinach every day, tell them to maintain eating spinach every day while they're on Coumadin, because that will affect their INR level. So if they were eating salad every day and then they stop, that's going to affect their INR. Their INR is going to go up and increase the chance of bleeding because it's no longer counteracting for the vitamin K they thought they were getting. So basically, the reversal agent for warfarin Coumadin is vitamin K or aquamethitonin. So basically what you're going to do is you're not really stopping the reversal of warfarin. You're just going to increase the amount of vitamin K to the point that's going to just override the warfarin and have a clotting effect. General note on anticoagulants. The one I have here pretty much is Pradaxa. So any oral anticoagulant besides heparin and besides, well, heparin's not an oral anticoagulant, it's an injection, or Coumadin is you need to be aware of they are not reversible. Generally they have decreased chances of bleeding effects, but you can't have any sort of reversal agent if they do have complications from bleeding. And also aspirin. Aspirin's a big one. So if it's going to be for stroke or heart attack prophylaxis, it's going to be the 81 baby aspirin once a day. Major thing to be aware for that is going to be a tetanus, that ringing in the ear. Alright. So another one, antiplatelet medication to be aware of is Plavix or clopidogrel. I probably butchered it. This one is primarily used in patients who have new onsets of AFib. If they had a cardiac cath, which is where they go in and bust up the plaque in a vessel in the heart, they will prescribe them Plavix to help decrease the effects of platelets binding together. It does not affect your clotting factors. It just kind of helps keep the platelets from just adhering together. You will want to do generalized PT, INRs, APTs, just kind of make sure where they are at a baseline. And then be on the lookout for any sort of liver damage caused from the medication. Next is going to be a thrombolytic. So a thrombolytic, this is what's going to actually dissolve a clot. This is going to be streptokinase or alteplase or TPA, as most people probably know it. So what this does is you can actually, so if someone has a stroke, they are aware of what type of stroke it is. They can actually put a cath into the brain, right into the artery, and just slowly drip a little bit of TPA onto the clot and dissolve the clot localized, so you have less effects of systemic bleeding. So the problem with thrombolytics is you have a huge risk for bleeding because you are basically effectively destroying every clot in the body. You're kind of making it hard for the body to form clots, and you're going to increase their coagulation time. So you're going to have a huge increase in your PT, your INRs, and your APTT. So if you're giving it for a stroke, the first thing you have to do, this is very important, is you're going to do a head CT first. A head CT will only diagnose a stroke if it's hemorrhagic or ischemic. If it's hemorrhagic, then you'll see something on the CT, that you'll see the blood in the brain going, okay, we had a stroke, it's hemorrhagic, we are not going to give TPA because they're bleeding out in their brain. But if they had signs of a stroke, do a head CT and they don't, so it shows no signs because you won't see a stroke on a CT unless it's a hemorrhagic. So you see a stroke symptoms, go in for a CT, don't see a bleed, then you, okay, we know you have a stroke, they have signs and symptoms, and they don't have signs of bleeding in their brain, we can give TPA. So depending on the facility and how up to date it is, they can either just do general slow IV infusion and give TPA out the body and slowly diffuse it, or they can do, like I said, do the localized cath to the artery site and just have TPA go to that one specific spot where the clot is. The problem with thrombotic stroke is you only have like a 3 to 4 hour window before the TPA can be used to get there to reverse the clot, to reverse any neurologic damage. After that 3 to 4 hour window, it's pretty much null and void. TPA is not going to do anything. The brain damage, brain's already dead. You can't reverse it. There is some current literature out that says if you go to a localized TPA right to the site, you can give TPA up to 24 hours. But generally for your test, it's going to be a 3 to 4 hour window. Head CT first to ensure it's not hemorrhagic. Now, say you give them a thrombolytic and they're just bleeding out everywhere. What can you do? So you can give a hemostatic. So hemostatic is going to help promote clot formation. This one is basically Amicar. So Amicar is going to just basically increase, like, your clotting factors go into overdrive. So you're going to start making clots, helping your body clot things up. Big thing to be aware of with giving Amicar is if there's some sort of a trauma patient and they're in DIC. DIC is disseminated clotting time, or something like that. Basically what DIC stands for is it's what happens when you have bodily trauma throughout your body and there are small clots forming everywhere. Basically it's so much trauma your body doesn't know what to clot off where. And so you have small clots forming everywhere because your body is just going in overdrive. You got clots all over the place. All your clotting factors are getting used up. And so DIC usually ends in someone just bleeding out because they can't clot anymore. But if you're going to give Amicar and someone's in DIC and they got those small clots forming all over the place, kind of irregular, you give them the Amicar, it's just going to cause all those clots to just form larger, and you have huge risk for strokes, huge risk for heart attacks, MIs, PEs, what have you. There is actually a medication that you can use for DIC. I can't remember the name of it. I only gave it once. It's very expensive. I will look it up later and I will post it in the comments of this video. But basically what it is for patients who are in DIC, and it's like 4 or 5 clotting factors you give, and it works within 10 minutes. So I gave it once. It was very expensive. Basically you infuse it just by their weight, and within 10 minutes you will see their bleeding stop. So the patient I used it on, it was a woman who had gangrene in both of bilateral thighs. They debrided surgically down to the muscle and tendon, and she was basically just bleeding, oozing straight from her thighs. Wouldn't stop. Pack it, called the surgeon. Surgeon didn't care. He's like, well, It's just generalized weeping, nothing I can do. And so the intensivist called, ordered the medication, and I was like, within 15 minutes, her legs stopped bleeding. She was more stabilized because I was just hanging blood after blood after blood, kind of just sleeping it out. But I will look up that medication and I will post that in the comments. So the next thing from here on is going to be biologic growth factors. So the first one is epoetin alpha, or Procrit. This is going to stimulate the growth of red blood cells. This is going to be predominantly used in dialysis patients and patients who are in kidney failure, because your kidneys, remember, are the ones that kind of release that epoetin alpha, which is used to make red blood cells. So if your kidneys aren't functioning correctly, you're not getting the epoetin alpha. So the Procrit is basically kind of like a synthetic epoetin. It's going to help stimulate the red blood cells in your body. So the huge complication with this is you're going to be increasing the blood concentration, and so you're going to end up causing hypertension because you're going to increase the solutes in the solution of your blood. You're going to have to diffuse more liquid and fluid into the blood to kind of thin that out. You're going to end up increasing your blood volume, causing hypertension. So be aware of anyone with a history of hypertension, uncontrolled hypertension. That's going to be basically your main side effect. Also, you're going to want to just be aware of checking their RBCs and seeing where they are. They may still need transfusions. Most hospital policies will not transfuse blood until their hematocrit is under 7. Some places are different. Some places use a magic number of hematocrit of 8 and hemoglobin of 24. It kind of depends on the policy. I would probably just verify for the test what numbers they're looking for, if that's important. Next is going to be Neupogen or filgrastim. This is going to be a growth factor for neutrophils. So Neupogen is kind of, a lot of your growth factors the names are very similar, so you have to be careful. So Neupogen is going to be for neutrophils. So this is going to help increase your white blood cell counts after bone marrow after like cancer, AIDS, bone marrow transplant, something like that, where their immune system is pretty much wiped out. The other thing you're going to see is you're going to have like bone pain in a lot of these. That's basically because the bone marrow is creating so many cells so quickly. It's kind of just like expanding out onto the bones and just compressing it and just causing pain. The other thing you need to be aware of is making sure their white blood cell counts, the absolute neutrophil count, and their platelets are within range, not too high, because you can't stimulate them to go too far. The other thing you need to be aware of is if they had any previous leukemia in the past. So leukemia, basically, if you're not sure what that is an immature white blood cells flourishing throughout your body, and so you're going to basically be stimulating white blood cells to grow, and so it's going to be for any cancer but leukemia. If you have leukemia, you give them Neupogen, just be basically causing your leukemia to go out of control and kill them so much faster. The other thing to be aware, next one is going to be interleukin or Numega, and this is going to be growth factors for platelets. So some of these are, like I said, these names are similar. So Numega is going to be platelets. Neupogen is neutrophils. So try to understand that interleukin is platelets. Interleukin, Numega, platelets. Neupogen, white blood cells. And then I kind of skipped it, but leukin is going to be white blood cells. So Neupogen, leukin, white blood cells. Interleukin, Numega, those are platelets. So they're very similar, so you have to look at them. They will be on ATI, and they'll probably have both of them there, so it's up to you to kind of remember which one's which and go with it that way. The problem with leukin and Neupogen are pretty much the same side effects, same symptoms. For your interleukin Numega, for your platelets, you're going to want to be aware of edema. Okay, I am back. Sorry about that. I have a new little companion with me. I have my little daughter, Cora. We're going to attempt to feed her and finish this video at the same time. So, as I was kind of saying, Neupogen is going to be for neutrophils. New mega platelets. Leukin is white blood, all your white blood cells, and then interleukin is platelets. So for all of these, you're going to need to kind of be aware of. You're going to be can lead to hypertension, edema, fluid overload. Basically, you're increasing the concentration in the bloodstream, so you need to dilute more fluid into it to help dilute the problems out. I'll dilute the other solutes. The other thing to be aware of, especially if epoetin alpha, is you can lead to possible stroke or chest pain just because increased red blood cells are going to they can build up and then cause clots or attenuate clots in your body. Ooh, little noisy baby there. Alright, so the next portion I'm going to try and get through fairly quickly is going to be replacement products. So I'll kind of go through this fairly. There's not much to it. You just need to be aware of are ABO factors, which I think everyone kind of knows blood typing, and then RH. Is there RH negative, RH positive, A, AB, B, or O? O is universal donor. AB are universal recipients. They can take any blood. Otherwise, it's just A for A, B for B, O and O, but AB can take a little bit of everything. So if you're going to give someone whole blood, what you need to be aware of is you have to type out both ABO and the RH factors. Same goes for packed red blood cells, and then also for granulocytes, which are pretty much your white blood cells. So any actual either whole blood product, packed red blood cells, or white blood cells, you need to be aware of both the ABO and the RH factors. So with whole blood, I can pretty much guarantee you'll never give whole blood unless you become a trauma nurse. Whole blood is only used now in very few cases when someone's bleeding out so quickly. You just need to give in blood volume as it's going out. Generally, you're just going to give whatever is missing, be it packed red blood cells, platelets, clotting factors, white blood cells. You'll give those. So with your whole blood, your huge major complication is going to be fluid overload, but there are, of course, other reactions. I'll get into the reactions a little bit. For fresh frozen plasma, that you only need to type in ABO. Fresh frozen plasma is basically the plasma blood, so that's just rich in your clotting factors. So if you have someone on warfarin, heparin, or who's in DIC and you kind of want to replace those clotting factors quickly and they're bleeding out, you can give fresh frozen plasma. And then you're going to give FFP and probably also some platelets along with it, but the FFP is going to be the major complication because they may not have enough, might have enough platelets, but they ran out of clotting factors, so FFP is going to be your go-to. And then you also have albumin. Albumin is not truly a blood product. Albumin is basically protein. It's like a protein solution, and so you need to type ABO or RH. Just kind of, it's like a free for all. You just give it. So, transfusion reactions. Basically, what you need to know is the major ones. First of all transfusion reactions per the textbook are life-threatening. So if there's any sort of reaction, you stop the pump, and you will have another saline liter bag with a separate primed line ready to go in case there's a reaction. So if there's a reaction, usually happens in the first 15 minutes. So you're going to assess your patient, get their LOC, get their vital signs, and then you're going to sit there for 15 minutes, check them again, check their LOC, check their vital signs, and look for differentiations from the norm. If they are experiencing any sort of reaction, increased hypertension, loss in LOC, or if they're having, the major one is the lower back pain, which is kidney pain, which is going to be indicative of a hemolytic reaction. You're going to want to stop the infusion initially. It's your first thing is you always stop the infusion. And you're going to send everything down to the lab. Ooh. Generally speaking, you're going to check the blood with another nurse. You're going to check the donor number, blood band to the patient, to the bag, vice versa. But if there's any reaction, you first stop it. Then you send the entire line down to the lab for testing. Because assuming the nurses you checked it off with did not screw up, everything should have typed and crossed correctly. There shouldn't have been a problem. So they're going to test that blood again and re-type and cross the blood that was given to ensure there's no complications. Oh, you are a slurpy little thing. Hemolytic reaction, your main thing is going to be cold, clammy tachycardia, but that lower back pain, which is basically caused from the lysis of the red blood cells that are typed incorrectly. It's going to be a huge increase of myoglobin, which is toxic for your kidneys. That's where the kidney pain comes from. You also have a febrile reaction, which is basically an increase of temperature in 1 degree. This generally, along with mild allergic reaction. You okay there? Most hospitals don't really view those as transfusion reactions. They'll just pre-treat with Tylenol and Benadryl and then call it a day. But per your textbook, any reaction, be aware of. Mild allergic reaction is just going to be some itching, flushing, things like that. Now the anaphylactic reaction, basically is like anaphylactic response, basically anxiety, loss of airway, shock, and the other one is circulatory overload. This one, like I said, is only going to happen if you're giving too many blood products at once or if you have whole blood. So generally, if you're going to give like 5 units of PRBCs, what they may order Lasix in between unit 3 and 4. And so they are where you are giving a lot of fluid to the patient. And so you just kind of need those red blood cells, not a lot of the extra fluid inside the bag. And so you will basically give them that Lasix in between, kind of diurese them out a little bit, and give them what they need back in. The other thing you can see is a septic reaction, but the septic reaction is basically going to be seen several days after. You won't really see a septic reaction right away. I believe I covered everything. If I missed some things, let me know. I'm also going to try and look up like I said, that magical clogging factor elixir for DIC. If you have any questions, let me know. If I missed something, I kind of lost track when baby Corey here got upset. Otherwise, let me know, and I'll have Corey wave goodbye to everybody. Oops.